I'd like to acknowledge the local custodians of the land on which we're meeting this evening and honour elders past, present and emerging. I'm sitting on beautiful Darkinjung land at Avoca Beach on the central coast of New South Wales. So welcome everybody. Thank you for being here with us tonight. It's a really interesting topic and a really important one and very timely as well. Thank you to the presenters for being here with us. Very busy time and we do appreciate you joining us this evening. So I'll just start with the introductions. Tonight we have Dr. Michelle Redford with us from Black Butt Surgery. Welcome Michelle, thanks for being with us. We've got Dr. Jo Wood and she's from the COVID care community with Hunter New England Local Health District. So welcome Jo. Dr. James Newcombe from Douglas Hanley Moir. Thank you for being with us. And Dr. Mark Lowenfall from the Living with COVID in the Communities, Medical Director of Infectious Physician. So thank you and welcome as well. Just a little bit of housekeeping. We are being recorded tonight and a copy of this will be available in our education library for you to access in the coming weeks after the event. A copy of the presentation and the recording and any resources that we discuss will also be there for you to access as well. It's a bit of a one-stop shop where you can access those resources and it's proving very, very popular, so feel free to access that at any time. We do have a handout in the handout section with us tonight as well, so you can access it directly there, or if you miss that you can grab it in the education library as I've just said. So after the event we will have the poll that will pop up and I strongly encourage you to please complete the poll. This information is really important to us and helps us plan future events, so strongly encourage you to do that. Also please, if you have any questions, this is your opportunity to have those questions answered, and at the end of the session we'll go to the panel and have a look at the questions. So if you pop those into the questions box, Dr. Michelle Redford is going to keep an eye on those and we'll get to those at the end. All right, I'm going to hand over now without further ado to Dr. Michelle Redford. Thanks Michelle.
Thanks, Melissa, and thanks for that lovely welcome. Very glad to be here. Thanks for having me. And I'm coming to you from a Wabble country, and I also would like to pay my respects to elders past, present, and emerging. So I'm a GP at Black Butt Doctors in New Lambton. I'm also the GP lead for Living with COVID for Hunter New England Central Coast PHN, and I'm just going to be taking you through some of the hot topics, things that have changed in the past month or so since we last had one of these webinars. So what's changed? So before I just crack on with that, just a reminder that Health Pathways is your go-to for all referral and management information in your locality. This is the Central Coast Health Pathway, and I've just circled there the link to the Hunter New England Central Coast PHN COVID-19 FAQ for general practice. So if you can't find it on the PHN website, it is linked to from the Health Pathway. And this is the Hunter New England Health Pathway. So there's, again, that's where that COVID FAQ is housed. Now, the FAQ is probably coming to a little bit towards the end of its natural life. The rate of questions and change that we're getting at the PHN related to COVID is slowing down significantly. So we think that's probably going to be archived in about a month or so, but information will still be available on Health Pathways as before, and you know, that's where we all need to go. That's the main thing about that. So what's changed? One of the main things that's changed, and that does inform the rest of the discussion, is that there is this emerging evidence of reduced efficacy of sotrovimab against Omicron BA.2. These other things, the notification of higher risk patients, we're going to go through in some detail. Jo and Mark a bit later on are going to talk more about antiviral prescribing. I'm just talking a little bit more about some of the public health changes and also some of the changes that have happened to immunization. So sotrovimab, you probably have seen that there's some emerging evidence that it just doesn't work as well against the strain that accounts for most of the COVID that we're seeing in New South Wales. So oral antivirals are now first line. So I'm sure Jo and Mark at COVID Care in the Community are seeing their referrals for sotrovimab drop off significantly. And the key thing about this is that GPs have a key role to play in prescribing antivirals for their high risk patients. So that links into this. So as of the 12th of May, this new model has gone live, and this is where Health Direct notify general practices about their higher risk patients. So I'm just going to take you through this a little bit. So what happens when you test positive for COVID and you register your RAT with Service New South Wales, or you get a PCR back positive from the lab, is that you then get sent a questionnaire by SMS with lots of questions about, have you got severe asthma, have you got immunocompromised, etc. And then those questions are used to just identify the highest risk patients, and it is quite a broad, it has to be quite a broad identification process. So the idea is that it probably picks up more people than are eligible. Then with that, there is an SMS that goes out to patients, and this is what it looks like, telling them, really you should be getting in touch with your GP. And there is also a secure messaging notification that goes out to the practice. Now, it's the practice nominated by the patient when they fill in the questionnaire. Then, and I'll show you what that looks like in a sec. And Health Direct then follow up that secure messaging notification with a phone call to the practice to alert them that they have a notification. So I think some of our GP colleagues who've been advocating in this space have really worked very hard to try and make sure there was a bit more information and it wasn't just a secure messaging notification going into the ether. The idea then is that the patient has some kind of clinical assessment from a GP within about 24 hours. And, we can debate the ins and outs of that, but that's the idea. And what it is not an instruction to prescribe. It really is a prompt for a clinical assessment. And as part of that, I would just remind people that these are patients that are at higher risk, and therefore potentially they would benefit from pulse oximetry and clinical follow-up. And so it's not just about the antivirals. There's a lot of focus on the antivirals, but we maybe need to think about some of the other bits and pieces. So that's the link. You can find more information there. This is what you get when you go there. So this is just the whole system of the process. So for practices, they really need to identify their own process of where this secure messaging notification goes, because it's not going to come into your inbox like your results do, because it's not going to go to a named GP, it's going to go to the practice. And so you really need to identify a person within the practice that is going to check that inbox really on a daily basis. And that might be the lead GP, it might be practice manager, but you need to make a process really so that you can find those notifications. Yes, you're going to get a phone call as well. And then you also need to develop your plan for what you do when you get that notification. And that might be, well, we have a doctor on call system and maybe we'll deal with it that way. Or maybe we'll say, look, we have no capacity, we're booked up for 2 weeks, in which case when Health Direct phone you, and if you have no capacity to do this work, you need to tell them that you don't have any capacity to do this work, and they will then pass that referral on to the GP respiratory clinic in the first instance. So, there's not a defined, this is how you must run your process within your practice, because there's a recognition that practices all run differently. But I think what I would be saying to people is, please make sure you have some sort of process in place. The other part of that is that this is not a referral and a clear transmission of clinical responsibility. It has been couched as a notification. And so whilst you have been notified, you haven't necessarily taken on full clinical responsibility for that patient. But I think, the onus is on you, to some extent to say, look, we haven't got capacity, and so please, can you make sure that this patient does receive their care in a timely fashion? And, patient also could ring Health Direct and say that if you're not able to provide that consultation. And the other thing about this is that, I would expect these consultations are happening by telehealth, hopefully video, or phone if necessary, and there isn't any obligation to see these people face to face. Look, there may be a small proportion of people that do need to be seen face to face if you're equipped to do so. But it's certainly not the default. Happy to take questions on all this stuff at the end. So this just summarizes the changes from the previous model and just sort of tells you some of the nitty gritty. And this is what the notification actually looks like, and some of you may have already received these. That's just really for information. So some other bits and pieces about COVID. So hopefully everyone's across this stuff now, because it changed probably a couple of weeks ago now, but there is now no requirement for isolation or routine testing for 12 weeks following recovery from COVID-19 infection. So that includes household contacts. So if you've if you've had COVID in the past 12 weeks and someone else in your household tests positive, then you're not, well, actually, yeah, I suppose no one's isolating now as household contacts, but anyway, you don't have those same requirements. But as probably all of us are aware, there is a whole lot of respiratory illness circulating, so to consider other causes, some of those patients might need a respiratory PCR or something, clinical assessment, even if it's not COVID. And the other part that's changed is that now ATAGI advice is to wait 3 months before giving the next dose of the COVID-19 vaccine that's due, and that includes if they've not been immunised at all. So if it's the first dose that you're waiting for, you're now in the situation where you wait 3 months. Remember before, it was like a 4 to 6 week window. You could give it straight away or wait 4 to 6 weeks. Now it's quite clear it's 3 months, and that includes like the winter booster and things. So that's making it quite difficult, isn't it, to plan clinics, because half the world seems to have had COVID, and so trying to time people's vaccinations is getting a bit tricky. But the idea of this is that it's, you know, pushing your immunity further down the track so that you get more protection over a longer period of time. Importantly, you don't need to delay flu shots or anything like that. Crack on with the flu shot and other immunizations that are due. And I think it has kind of changed or tuned a little bit around the exemption forms, the AIR exemption IM011, which now potentially, you know, if someone has had definite COVID and you've got some documentary evidence of that, you can fill in a form saying that they've got a 3-month exemption from vaccination based on, I think the ticky box is major medical illness for 12 weeks. You do have to upload it via PRODA. Okay, so this links in really with what Joe and Mark are talking about. You're probably all aware that from the 1st of May, Paxlovid, nirmatrelvir plus ritonavir now on PBS, along with its little friend molnupiravir, Lagevrio. So they both have the same PBS indications. They did change just in advance of the 1st of May. Paxlovid is first line. It's got lots of drug interactions, including with the torvastatin and various other commonly prescribed drugs. So make friends with the Liverpool COVID-19 interaction checker, get it bookmarked, because it is a beautiful little tool. So you can put in the medications that the patient's on, and it will tell you what issues you've got. I'm sure Joe and Mark are talking about that as well. Private scripts discouraged, and that's for a few reasons. And firstly, because it costs more than $1,000 on private script, but also because the clinical criteria and PBS criteria are pretty closely aligned. And so if you're needing to do a private script, I'd be wondering, you know, why and whether it truly was indicated in the best interests of the patient. The other thing that I've been doing is talking to some of my higher risk patients in advance and actually checking some of their drug interactions in advance, and sort of saying to people, well, look, you know, if you test positive for COVID, well, if you get symptoms of COVID, first off, do a RAT. If your RAT's negative, go and get a PCR. And then, you know, if you have a positive test, then I want to know about it, and please phone the practice. And look, you're eligible for this drug, you know, whether it's molnupiravir or whatever, and you know, some stuff about that. I think it's quite helpful now that we've got so much COVID around that maybe it's worth doing. Also things like, you know, making sure they've got an asthma plan and they know to follow it if they've got asthma, and stuff about sick rules, you know, stopping your SGLT2s and all those sorts of things. So just very quickly, these are the PBS criteria for antivirals, you know, that you've got a positive test, you're symptomatic, and you don't need to be in hospital, you're in within 5 days. And this is the simplified criteria, and I think, you know, probably again, Joe and Mark will look at this again, but age 65 plus with 2 risk factors, or 75 plus with 1 risk factor, or Aboriginal Torres Strait Islander age 50 plus with 2 risk factors, or age 18 and immunocompromised, and that's according to the ATAGI definition, which hopefully we're all across by now. But it is complicated, and I think the questions as well on the questionnaire do pick up quite a lot of people who potentially, they say they're immunocompromised, but they're probably not really, and certainly not according to the ATAGI definition. These are the PBS risk factors. I won't go through that in any great detail. This is the immunocompromised thing from ATAGI. So, you know, I think we can all be forgiven for not having it in our heads. I think the key thing is to know where to find it. And, you know, I suppose I have some of these drugs that are my patients seem to be on quite a bit. You know, like I seem to have quite a few patients on infliximab, for example, and I now know that, you know, that doesn't count. But it's just going to require looking up, I'm afraid. There isn't really a way of simplifying it. Okay, moving on from COVID to COVID immunization. So again, you may have known or heard that the interval now between the first and second doses of Pfizer or Moderna in adults has moved to 8 weeks. So it was 3 weeks for Pfizer, 4 weeks for Moderna. It's now 8 weeks. And I mean, I think we're probably not doing a whole lot of primary course, but anyway, that's just to remember. Winter boosters have come in and hopefully are well underway. Only for selected groups. There's still no plan right now for a 4th dose for healthcare workers, etc., who had their booster way, long ago in the mist of time, sometime in 2021. But apparently Atagi are looking at that on a repeated basis. Remember, there are no boosters for 12 to 15-year-olds. So there was a bit of confusion because the TGA actually approved Pfizer as a booster in this age group, but it is not recommended by Atagi. So please don't start doing that one. Moderna and Pfizer still preferred. AstraZeneca if you can't have an mRNA vaccine, but not if you've already had 2 doses of AstraZeneca, because that seems not worth doing. And Novavax is available as a booster, not TGA approved, but if no other vaccine is suitable. So that's that. And I've always talked about delaying COVID-19 vaccine for 3 months post-COVID. Winter boosters. So these are the criteria for winter boosters. Again, it's that 4 months after the first booster. So you're now on a primary course at 8 weeks apart, so 2 months apart, and then your first booster 3 months later, and then your winter booster 4 months later, and also 3 months from your COVID-19 infection. Starting to get a bit complicated, really. Adults 65 plus, people who are in aged care and disability care facilities, and there is a role for us here because it's not like first time round when everybody was due their vaccine all at the same time, and you could potentially organise like an outreach service or a third party, which they were contracted by the government when they to go in and do those first doses. Now people, because a lot of people have had COVID, a lot of people are going to be due at different times. So if you are able to get involved with those sorts of patients, that is fantastic. They're high risk and they could really benefit from a winter booster. Also remember those patients who are in group living situations, maybe people who are living with a disability. Those patients are not easy to identify through coding in our practice systems, and so just to be aware of those and target those people for a winter booster. They're high risk. And then the 16 years plus with severe immunocompromise and Aboriginal and Torres Strait Islander people 50 years and over. So for the severe immunocompromised people, for your adult with an mRNA vaccine, it's now first dose 2 months, second dose 2 months, third dose 3 months, booster 4 months, winter booster. So it's 2, 2, 3, 4 for the 5th dose. Oh, it's confusing, isn't it? If in doubt, look at this lovely slide, which has come from Atagi and tells you what to do. So that's the link there, and that will help you when you're more complicated patients. What does up to date with COVID-19 vaccination mean? It still does not include the winter booster, and so being up to date just for an adult age 16 plus means that you have had your primary course and a booster. And that's the same if you're immunocompromised. It just means you have to have had a 3-dose primary course. And for 5 to 15s, it just means you've had your primary course. Flu. So hopefully everyone is cracking on with their flu vaccination campaign. You can give any COVID vaccination with any type of flu shot. Please don't be delaying your flu vaccine to give it on purpose with the winter booster. Just give them when you can. Pharmacy in New South Wales this year can give all NIP vaccines, including Fluad Quad for the over 65. So that's a new thing. So do just watch out for that. And a change in National Immunisation Programme funding for New South Wales, which includes people with a BMI of 30 plus. So the eligibility has expanded for the first time since I've been looking at that, which is about 8 years. So just watch out for that as well. Important point is to know your brands. Don't give anybody a Fluria Quad if they're under 5, and Fluad Quad is only 65 plus. Lots of queries about billing. So you can bill them separately as long as you meet the descriptors. It's not mandatory to bulk bill vaccines that are available in the National Immunisation Programme, but it is mandatory to bulk bill COVID-19 vaccination assessment items. that's the one page that came out from the PHN trying to clear up the billing. As you can see, it's complex, and so that's a good resource. Changes to household contacts. So like the headline was, you don't have to isolate anymore if you're a household contact, but of course there is still some rules. Once again, you don't have to isolate if you've had confirmed COVID in the past 12 weeks. If you've got symptoms or you're a confirmed case, you still have to isolate. But if you've got no symptoms, you don't have to isolate, but you still can't really go to a high risk setting, which includes general practice. So I've got a slide in a second just about healthcare workers, but the advice is still to work or study from home if you can. The employers have to put a risk assessment through before they get you back to work, and you're supposed to still wear a mask in indoor settings that are not where you live. Plus, you're encouraged to wear a mask at home and take a rat if you need to attend an indoor gathering, but try to avoid them. So it's not just carry on as normal. I think that's a point that kind of got missed a little bit in the news items and things. So, and then this is a great resource for healthcare workers, and this applies to general practice. And it's one of the actual first times that we've, in this whole pandemic, that we've had something that was really a bit more applicable to general practice. Really, in terms of healthcare workers who are household contacts, not much has changed with this change in rule, because this is kind of pretty much what we were doing anyway. So the idea is that you isolate and work from home for the first 7 to 14 days. But if you're critical to service delivery and you can't work from home, then potentially your employer can get you back to work face-to-face with risk mitigation strategies, and which is the same things as we talked about repeatedly, which is, continuous P2N95 wearing and avoiding unmasked or close contact with other people, and the daily negative rat. So really it hasn't changed much. So this is a great resource, and I would direct you to that. So that is all from me, and I will pass over to Dr. Jo Wood and Dr. Mark Lowenthal from COVID Care in the Community for their presentation on antivirals.
Thanks, Michelle. I'll just get it up quickly. And I think, hang on. Hopefully that's working for everybody now. Thanks again for having us present tonight. I'm presenting tonight with two hats on, really. One as a GP working with the COVID Care in the Community team under Dr. Mark Lowenthal and his medical directing there, and also as a clinical editor for the Community Health Pathway, which is really driven in large by the amazing Sandra Fitzgerald, but I'll be referencing that throughout this talk. So we've got here some key points that we want to sort of work through with you guys, how to apply the National Evidence Task Force guidelines to some clinical scenarios, to demonstrate how we're using the Liverpool Interaction Checker, and just to discuss the prescribing options that we have available for people with COVID-19. Quick reminder, username, password, I'm sure everybody knows now. This is a screenshot from the Community Health Pathway. We've got the initial consultation section. It's a medication drop box that we use frequently in our work at the COVID Care and Community team, and is the resource that I draw attention to when people ring up for advice, when we have GPs ringing up about asking for advice on how to make a decision about whether to prescribe or not to prescribe for their patient. So in that Dropbox there's some important steps to go through. I'll be talking to the tools that we use particularly in these steps. Important, of course, is to assess the eligibility, which Michelle has already sort of alluded to. So those important questions: is the patient actually COVID positive? You'd be surprised how many people we see that aren't actually COVID positive get referred into us. Is the patient within the first 5 days of symptoms? Is the patient immune compromised? If they're immune compromised, as Michelle has described, it's as per that ATAGI documents definition for third dose vaccine that we're usually using pretty much. Then you can just keep going. Don't really have to work out too much. There's some definite exclusions. Patients that are under 12 years cannot get anything. Recently been approved for 12 to 18-year-olds for Paxlovid, but in terms of practical experience, that's not happening really yet, and certainly is a job for the COVID Kids at Home team. And then really it's just women that are pregnant can't use these oral antivirals either. So there's 3 tools that I'm going to just draw attention to quickly. This is a flowchart that's been developed by the National COVID-19 Evidence Task Force. It's busy and there's lots of stuff on there, but if I can encourage people to become familiar with it, I think it would be a very, very helpful tool for you. And it's certainly what we use to help reinforce our decisions when we're working out whether someone should have an oral antiviral or not. This is a tool. Now, if you see, I've circled there the risk classification tool on the far right. This is this picture here. Now, that's for those people that are in the in-between zone and you're trying to really decide is there benefit or not for prescribing. Again, probably a little bit confusing the first time you see it, but definitely very, very useful when you're making those decisions. And this is the drug interaction checker that's been developed by the University of Liverpool. So we're going to talk to a clinical case and just show you how we're using these tools. So it's a 74-year-old lady. She's on day 3 of symptoms. She's had 3 of her COVID vaccines. She's got asthma, type 2 diabetes, and has a BMI of 30. Her medications include salbutamol, metformin, aspirin, atorvastatin, Symbicort, tiotropium, prednisolone, which she takes for asthma flares, and she's had to use that twice in the last 12 months. So going to that flowchart that we pulled up, it's in that first step of the health pathway in the medication Dropbox. We can see here that we can start, we check and see if she's immunocompromised or unvaccinated. Nope. Is she up to date with her vaccinations? Yep. What do we need to do? We need to treat the symptoms and observe. Don't need to do anything else. But what if she'd only had 2 vaccinations? That's when it becomes a little bit more interesting. So if we go back to that slide, we've come along here. She is not up to date with her vaccinations. We don't immediately need to proceed to prescribing unless she's at risk of severe disease on the basis of age and multiple risk factors. So that's where we pull up that next tool. And we can see here, as a member of the general population with multiple comorbidities who is not up to date with her vaccinations, she's flicked over there at the age of 74 into that high risk of severe disease category. So the next question, of course, is which one shall we give her, Paxlovid or molnupiravir? There's a few quick things to think about that might help direct you straight to molnupiravir. That would be if there was severe liver impairment, severe renal impairment, an interaction with one of her existing medications. The next sort of job that you need to do is work out if you're going to do a PBS script or use the hospital pharmacy pathway. I'm going to hand over now to Mark, who's going to just talk about balancing up those 2 medications and what we know about them. Thanks, Mark.
Thanks, Jo. Thank you for asking me to talk tonight. I'm an infectious disease physician, and one of my current roles is medical director of COVID care in the community. In a previous life, I was director of infectious diseases at the John Hunter Hospital. Now, when I come to the medications, I've listed 3 there, but there are 2 types of tablets available on the PBS. And can I start by saying that Paxlovid, nirmatrelvir, ritonavir, works better. However, it has many drug interactions. And Lagevrio, molnupiravir, has actually got no drug interactions listed, and it still does work, just not as well. And they're both oral. I've put remdesivir in there, Veklury, really at the request of Professor Davis, who is on the evidence-based task force, and he gave us a couple of things he would like us to say. So for people who for some reason can't have either, especially now that sotrovimab is definitely less effective, there is potentially the option of one more drug, but this has to be given intravenously on 3 consecutive days, which is a logistic problem for us anyway. So we'll focus on the 2 tablets. I'm just going to quickly give some results, remembering that in the licensing studies for each of these, no one who was vaccinated was allowed on a study. It was an exclusion. No one who was immunocompromised was on the study, either study. There was also an exclusion. Everyone on the study had other risk factors for progression to severe diseases, such as diabetes, ischemic heart disease, and so on. So, so the first thing is completely unvaccinated people with risk factors. The second thing is to say both studies were before the Omicron era. They were, in the case of Paxlovid, it was well and truly into the Delta era, and molnupiravir can be, to oversimplify, it can be split into the Delta era and the pre-Delta era, because interestingly, in the middle of their study, they had much better results than they had at the end of the study. And it's quite dramatic when you look at the results for molnupiravir, that it worked reasonably well against the pre-Delta strains and didn't work well against Delta at all. If we could move to the next slide, please, Joe. So, look, the two studies, all studies have to have acronyms. Paxlovid had the EPIC HR study, and Ligivrio had the Move Out study. Overall, the primary endpoint was hospitalization or death, and overall there was an absolute reduction of 5.2%, just under 6% for the Paxlovid. In fact, the Paxlovid group had less than 1% hospital admission rate. So it was definitely effective. And of the just over 1,000 people in each arm of the Paxlovid study, there was no one who died who received Paxlovid and died. None of the 1,000 people, versus 12 of the placebo people who died. So it definitely works. Ligivrio, and which while I'm there, you can see that in fact Vaccination had a similar magnitude of reduction, although their group had no deaths in either placebo or drug, and that's a drug that's used to treat people hospitalized with COVID. But interestingly, it actually has a larger effect on this group of people who weren't hospitalized. Okay, the other tablet, the molnupiravir, which virtually everyone can have unless they're pregnant, essentially had a much smaller reduction, 2.8% reduction. It's less than 3%, so sort of half the benefit. So so the sort of default is Paxlovid, and then we look at the drug checker and we see if there's a contraindication. And if there is, the contraindication is pregnancy, that's a problem. If the contraindication is a drug, then we go to molnupiravir. I have to say that the solid organ transplants, who are almost all on drugs that interact with Paxlovid, have been getting molnupiravir, and we haven't had a problem with progression in those patients. And so really only a very small number of people have been getting the remdesivir, essentially the very immunosuppressed group who can't have nirmatrelvir. I think if you have someone in that category, you'll be wanting to communicate with either us at COVID Care in the community or the patient's specialist, because they probably will have a specialist for whatever disease they have, which will be leukemia or some sort of transplant. That's all I've got to say. Back to you, Joe.
Thanks, Mark. So, as like Mark's pretty clearly pointed out, it's Paxlovid you'd be trying to get for this patient. So I've run her medications through the Liverpool drug checker. You can see there's different, like it's actually quite straightforward to use. It's worth having a play with. It's pretty good on the phone if you want to use it that way. These different representations. It's a table form. The little green diamonds there mean there's no interaction. The little orange one there is potential interaction, and the triangle is a weak interaction. And you can click on it and it gives you a bit more detail around that. Essentially with atorvastatin, it's a theoretical risk. They've recommended, I think here, if you read it, that you stop it for the duration of therapy and for 3 days after, or reduce the dose. The weak interaction with the budesonide there is just for your interest really, because they're not actually recommending that you stop the medication. So for her in this instance, on balance, we decided to proceed with Paxlovid. Now the trick is, of course, getting that script to the right place and getting it to her. We have been having really good success so far with the community pharmacies since the 1st of May, where they've been having supply of Paxlovid available on the PBS. We do tend to ring just to confirm that they do have availability, and in all cases they have either said well, actually I think they've all had to get it the next morning. So it's been fine if we've had enough days within the first 5 days. If we couldn't get it, like if we were trying to get it really on, say, the 4th day or the 5th day for a person, we would probably try the hospital pathway as well. So we can still do that as GPs. The prescription and declaration form for GPs is there in that Paxlovid drop box on the pathway, and the criteria are slightly different, but for her, she's eligible either way. So that brings us to our final case, which is a 49-year-old Aboriginal man who's day 3, he's living remotely in a small rural town. He's unvaccinated. He's got type 2 diabetes, he's hypertensive, he's got ischemic heart disease, he's had a non-STEMI with a stenting in May 2020, he's got obstructive sleep apnea, he's already on CPAP, he's got a body mass index of 40. He's on a collection of medications there: rosuvastatin, metformin, telmisartan, hydrochlorothiazide, semaglutide, Ducover, and empagliflozin. His kidney and liver function, fortunately, we have had access to, and his EGFR and LFTs were fine. So we again used the tool to try and help make a decision about whether he would benefit as an unvaccinated person within 5 days of symptoms. We decided that he would be a good candidate, but he's actually quite young, so he's not really going to leap out as eligible under the PBS criteria. So just to really confirm that in this instance, we would consider proceeding, because really, if you think about it, those people that aren't eligible, that are younger, it's on the basis of age and multiple risk factors. So this chap, as an Aboriginal man with multiple comorbidities, who is unvaccinated, regardless of age, is in that highest risk of severe illness. So we did want to pursue a script for him, and in order to do so, we had to do that via the hospital pathway. And that is the end of our presentation. So thanks, on to you, James.
Thank you. Thank you very much for those lovely talks, and I'm hoping you can see my screen now. So I'm Jim Newcomb. I'm infectious diseases physician and microbiologist at Douglas Hanly Moir. I want to talk about something that really relates to what the other speakers have talked about, which is getting treatment to people early and getting to the right people, and how something that we're doing at Douglas Hanly Moir, Pathology, with self-collected PCRs that is now available across New South Wales, is now available and helps to access treatment because you get an early accurate diagnosis for your highest risk patients. So for me, this is one of the most powerful images of the pandemic, which is right in the beginning in March 2020, the Pope in an empty square saying a prayer to end the pandemic. And although we've come a long way since then, we've got vaccines, we've got oral antivirals, which I think many of us 2 years ago had a lot of doubt that would ever happen. Unfortunately, the COVID pandemic is not over, and therefore accurate and timely testing remains essential, as it has for the last 2 years. So self-collected COVID PCRs we're going through, they're convenient, they're very reliable, and is putting back onto GPs the diagnosis and management of COVID, which is really a sustainable way that we're going to manage this pandemic moving forwards, especially with these antivirals on the PBS. So you may have heard this week and last that Australia does have the highest COVID case rate in the world at the moment. And we've actually caught up with the US in terms of cumulative COVID cases. So we've made up for lost time in a bad way over this year, really, end of last year and this year with Omicron. The most concerning part of that, apart from the disability and acute illness associated with that, is the death rate in this country is, I would call, unacceptably high. So we're sitting at about 1.5 deaths per day per million people, which is equivalent to the US and most of Europe, despite our high 2-dose vaccination rate. And that's, to put it into perspective, 3 times the death rate of the worst modern influenza season that Australia's ever experienced. And it's not just a season, this is basically every month since December, we've been getting this kind of death rate. So that puts us on track at the moment for about 15,000 COVID deaths in this country for this year, which actually makes it the 2nd leading cause of death in Australia. So we really all have a role in trying to get that death rate down, and early and accurate diagnosis, access to oral antivirals in the community is going to be a really key way of doing that. As the other speakers have said, obviously you need COVID positive people to put on treatment, and that's the best way of doing that is a PCR. The PBS criteria talks for a medically verified rat. I'm not even sure what that is, to be honest, but a PCR is going to be much more reliable than a rat. So Westmead did a study which was done under the best of laboratory conditions. They had viral culture, they did serial dilutions of that virus with both Delta and Omicron, and they used, on the 1 to 10 you can see on this slide, these were the rapid antigen kits that are available in Australia. So you can see that anything over a CT value of 28, which is about a medium viral load in the lab, those orange squares meant that those rat tests missed those. So if we look at the COVID PCR positives in our lab at DHM, that means at least 35% of the positive cases that we're seeing every day by PCR would be negative on a rat. And I'm sure that aligns with your experience talking to a lot of GPs and a lot of patients who've been negative by rat and then positive by PCR. That's a problem not only because people will be falsely reassured by rat, but also because it delays the diagnosis and that critical 5-day window that you have to treat. And obviously with anything antivirals, the earlier the better that you get in. So we have been using self-collected COVID PCRs for 2 years. We were the 2nd group in the world at DHM and other sonic laboratories around Australia to publish in this, and validated it as a quite appropriate alternative to clinician-collected swabs. And basically just as sensitive as clinician-collected swabs, and actually we picked up extra cases because people seem to be more willing to torture themselves with a swab than having someone else do it. And really what sparked us to offer this more widely at the moment is 2 things, and that is that most patients have done a rat, so that everyone's used to self-collection now, so that kind of barrier has been overcome, but also that with the oral antivirals available now, that there's a lot more impetus to diagnose people, not only for public health reasons, but for individual clinical use. So we have these self-collect swab packs, which are available if you're with DHM. There's a code that your practice manager can order these through stores at DHM, or our liaison managers in this area can help you. And at every DHM collection centre, the patient, once they've collected the swab, we've got instructions in there, they label the swab and they put it back in the bucket. But the other key part about this whole initiative is that what we're trying to do again is to put the testing back onto GPs. And Michelle talked a lot about planning in advance, and this is one way that these could be used. Those high-risk patients, when you're seeing them at your regular appointments, chronic disease management plans, for example, you know that if they ever had COVID, they would benefit from oral antivirals. So you can give them the self-collect packs in advance with a paper request form signed for respiratory virus PCR. And then you give them the instructions, if you ever get symptoms, then collect these yourself and drop them at any DHM collection centre. And that result comes directly to you. So you're not relying on Health Direct. that as just another pathology test which comes into your inbox by the usual means and comes to you personally. The patient also gets an SMS as well, but it means that you have that notification, your high-risk patient has COVID, and you can proceed to action that as you see fit. The other important thing is that unlike rats, we can diagnose every other respiratory virus which causes issues, and particularly influenza, which, as we all know, is causing a massive problem this year, unfortunately. Influenza A rates are going through the roof. I just wanted to finish off by letting you know that on the DHM website, we produce weekly respiratory pathogen reports, which are actually region specific. And that just outlines, this is the Central Coast one at the moment, outlines the percentage positivity for each of the major viruses. So you can see, unfortunately, on the coast where I live as well, the positivity rate's over 25%, which is the second worst in the state, and has remained stubbornly high. But you can see that line there, the influenza, that's creeping up quite steeply, and it's over 5% on the Central Coast. If you go to Hunter, New England, COVID's a bit better at 10%, but influenza is also rising there. So we do unfortunately face a very difficult winter where we need to identify people who are high risk and get early, accurate results on them. And so I'm hoping that this solution from DHM is something that can help GPs in what will unfortunately probably be quite a difficult season. So very happy to answer any questions. This pamphlet has gone out with our doctor's newsletter today, so that should be arriving in your inboxes this week. And again, thanks so much for the invitation. It's been great to be on this.
Thanks very much, Jim. I think we'll just get all the panel back on and we'll be able to answer questions. I think that's a real game changer for a lot of GPs actually, Jim, because we've really struggled with getting notifications. I think in the whole pandemic, I've had about 2 notifications direct from the lab for patients, who I hadn't directly requested the pathology for. So we've been relying on these other notifications. So I think that's a great suggestion as part of your planning with your high-risk patients to maybe give them a pack and things in advance. So we've got a few questions. Hopefully I can just direct those. So the first question probably maybe for Joe as a GP who's also in the COVID care and the community team. Are the best practice software warnings adequate for checking for interactions for oral antivirals, Joe?
I haven't prescribed through best practice because, most of my patients are well and truly under 20.
Well, I'll have to answer it then, sorry.
Yeah, no, that's all right. But I wouldn't have thought so. I think you probably need to stick with it through the
I would agree.
drug checker.
I would agree.
Yeah.
Stick with the Liverpool drug checker. It's actually got lots of information in there, and I wouldn't trust the kind of ones that are within the software. Okay, so what do you do when you don't hear about the COVID positive test for 5 days? Yeah, and this is the key issue, isn't it? And I think we've been getting our notifications mostly through the LHD in Hunter, New England, and they do take a bit of time because they're relying on multiple processes. And if the patients don't report their positive rat to Service New South Wales for a couple of days, then that delays it as well. So I think it's multi-pronged. So it's Robin that asked that question. It's an excellent question, but maybe part of it is Jim's suggestion about self-collect PCR, and we all take back control of our own patients, which would actually be nice. And part of it is educating our patients in advance and making sure the high-risk patients know that they have to get on with it and notify. Don't know if anybody else has other thoughts about that.
Went to a meeting today, Michelle, that that specific question was asked again about just patient education, because there's, the delays have definitely been happening for a while now. And there is apparently a bit of a New South Wales Health effort to do some social media stuff around, registering and doing it early and that kind of thing so that we can pick people up.
Thank you. Okay, so this is probably a question for any infectious diseases specialists, so either Jim or Mark can jump in. How accurate is the recipe for flu injections this year? Are the strains we're vaccinating against in circulation? Good question.
That's a good question. Look, I don't know if Jim wants to say something. So every year our strains are based on what's happened in the Northern Hemisphere when they've had their flu season. So we only know for certain after the flu season whether that's going to be whether they're going to match up. I haven't seen anything specific for this year yet. I don't know about you, Jim.
No, I think, influenza A, I think it's H1N1 is the predominant strain at the moment, and I don't think there's anything that suggests that it's not going to provide coverage against it. I think the real issue with immunity in the community for influenza is that we've had 2 fallow years where we've had no influenza in Australia, and the vaccination rates were very good in 2020 when everyone wanted to get a vaccine because you couldn't get a COVID vaccine yet. But last year was drowned out by the COVID vaccines and everyone forgot about flu. So the population immunity is not great. And I think, unfortunately, we're seeing that in the numbers. So there's every chance it'll be a bad COVID and influenza winter.
Thank you. Yeah, so we just need to get jabs into arms as usual. So another question. So thank you, John, for your question. For prescribing antivirals, do we count day 1 as the first day of symptoms or the day of the first positive test? That's to Joe or Mark, because you're the ones for doing lots of dealing with this.
Day of symptoms is day 1.
I mean, you have to have symptoms to be prescribed. If you have no symptoms, you don't actually meet the criteria for prescription.
Yeah. So within 5 days of symptom onset.
That's right. And as a doctor, you have to take the story and make up your mind as to when that is.
Yeah, great. Okay, and let's just have another look. So is the virus PCR test covered under Medicare, or is there cost to the patients? I think that's about the self-collected PCR. That's to you, Jim, please.
Yes. So the COVID PCR MBS item number is unusual in that it's mandated that it's bulk billed, no matter who does it. So the COVID PCR is the respiratory virus PCR. If you order it with DHM, is just as per your normal arrangements with DHM, which is almost always bulk billed, I'd imagine, from a GP practice. So yes, the Medicare item numbers, they're covered. People have asked an interesting question when I've been talking to GPs about this, which is, I talk about the cost of rats, which are $10 to $12 a pop. I know you get a few free if you're a concession card holder, but if you use them all the time, they're actually quite expensive for people. And obviously PCRs are more expensive to the government, but I would argue with the current death rate that we're having in this country and the case rate that we really need to be using the best test we have available. And we know that PCRs work, and we've been using them for 2 years. So I think the cost to the taxpayer, hand on heart, is worth it to try to get, and now more than ever when we have oral antivirals that can really save lives.
Yeah, great.
I think the thing is we want the people who are going to be eligible for the antivirals to be the ones to have the PCR.
Yeah, and so that's back to those conversations that GPs are well placed to have with their patients in advance, isn't it? And having that little summary together for their patient. I mean, I've got a little thing that I can print out now, which is, if this then that, and if this then that, and you currently look like you're eligible for, Paxlovid, and so ring us and tell us if you have COVID, so. But
yeah, I agree, Mark. In terms of pathology stewardship, which I'm very keen on, the idea is that people don't just go to drive-throughs when they have a sniffle or something. I think we need to move away from that and towards GPs ordering tests that are actually indicated because they make a difference to patients. So that's what we're trying to do with the self-collect initiative, is put the power back with doctors who know best how to order a test and whether it's worth it or not.
Yeah, probably the thing to add to that is we have lots of conversations with lots of people that are possibly would have been eligible and high risk, and they've said, and I had symptoms for days and my rat test was negative before it went positive, and so we picked them up at day 7 of symptoms, but day 3 of positive test. So if they had got known to maybe get a PCR earlier on, we might have picked it up a bit earlier.
And I suppose it's been confusing over time for patients, hasn't it? Initially it was all PCR, and then we moved to rats, and then so you can understand that, but yeah, we just can keep on educating. If a patient is eligible for both antivirals and Pulmicort, should we prescribe both? Joe?
Sure.
Let's see a reason why not.
Interesting, like a lot of people that are in that category and are old enough, you know, for the pulmicot, they're already on an inhaled steroid. So often it's a redundant conversation, because if they're already on an inhaled steroid, you don't need to do it to add it or change doses or anything like that.
But they do need to remember to follow their asthma plan if that's what they're on it for, I guess.
Yes,
yeah,
true.
Sometimes gets forgotten in the midst of COVID. What other questions have we got? Sorry, bear with me a second. Are the guidelines as clear on Central Coast health pathways as on Hunter New England health pathways? I'm not sure. I haven't done a side by side. I mean, I think, you know, both pathways are locally responsive and kept up to date. I think if you are having difficulty navigating, then it's important to give that feedback, and both pathways have got feedback buttons. You're encouraged to use them. So hopefully the health pathways team won't hate me for saying that. But you know, I think if you're finding it difficult, you know, nobody wants it to be difficult. So please do feedback, but all the information is there. And yes, there's another question about, are these flow charts and things, are they on health pathways? And they are, aren't they, Joe? Certainly on Hunter New England. You know, your like link to the interaction checker is there, and the COVID task force flow chart, all of those things are there, aren't they?
Yes, yeah. So they're very much, yeah, our work, like, you know, Sandra's done lots of work with coordinating with lots of GPs to try and get that nice and user-friendly, and a lot of the work that we do in the COVID care and the community team has helped inform that. So it's all there. This is what we think of first, this is what we think of second, this is how you do it. So, and I will do I'm having a quick look at the Central Coast pathway, and I think it's probably from so we have this New South Wales statewide collaborative pathway, and I think that theirs is very similar. So there's some slight differences, but very similar.
Okay, thank you. That's great. There is a question of, if a patient presented to the GP 5 days after the symptoms started and the GP ordered PCR and became positive, can we use antiviral because the symptoms are more than 5 days ago? I think you're limited really to using the antiviral within 5 days of symptom onset. You have a bit of a clinical decision to make about what day one was based on your history taking. But I think if you're beyond 5 days after symptom onset, then we're not using antivirals.
Now, can I say one thing about Omicron versus Delta, or pre-Omicron? You know, previously we had the big issue with the people getting hypoxic in the second week, and now we only very rarely seem to see that with Omicron. So the people who are at 6 or 7 days who've got better now seem to stay better. Having said that, if the person's becomes hypoxic, they need to go to hospital where they will get both antivirals and anti-inflammatory drug treatment as well. If you look at the remdesivir, it says you can actually get that to day 7, but by the time we'd organised it for an outpatient, we might have missed the boat as well. So it doesn't mean that so if they get sick, they need treatment, but they're going to have to go to the hospital for that. But a huge change since Delta is that the people who get better generally seem to stay better.
That's an important point, isn't it, Mark? That, you know, people generally are getting better by that stage, and so those ones that are still significantly symptomatic, you're pretty worried about, and you might need to actually get them in, see them face to face, or send them into hospital, or one of these sorts of things. So yeah, not just give them some antivirals at home. Yes. Okay. Well, I think that is about it for the questions, and we're pretty much out of time. I'm just going to have a quick run through and make sure we haven't missed any questions. But if anybody on the panel has anything else burning they want to say, please go ahead whilst I'm looking. No.
Remembering, if you have difficulty with getting face-to-face stuff done in your own clinics, that the respiratory clinics may have capacity in your area, fabulously staffed by wonderful GPs. So keep that in mind.
Excellent point. Yeah.
I think there's a handout as well in the GoToWebinar which has this flyer if you don't get it through other avenues, which just explains our process for the self-collects. So thanks, Mel, for putting that up.
You're very welcome.
And that's just direct ordering through usual processes, as you said, Jim.
Yes, I mean, the important thing if you're going to use it is to do a paper request form and ideally give it to the high-risk patients in advance, just part of your planning for that high-risk group. There's other ways that you can use it in terms of telehealth and giving them out on demand, but that's, yeah, there's different ways of using it, but you can order them directly through DHM.
Wonderful. Thank you.
Great, and thank you all for being here with us tonight. That was a really interesting session. And just a reminder that, yes, all the resources and a recording of the presentation tonight will be available in the Education Library in the coming days. And just a reminder to please complete that survey when it pops up at the end of the session. So thank you, everybody. I hope you enjoy the rest of your evening. Relax and enjoy. And thank you again to the presenters for being here with us tonight. Good night, everyone.